Hello, my name is Govind Rajan and I am an anesthesiologist and an intensivist at UCI Medical Center, and I have been doing this for a little over 30 years. Today I would like to share with you some novel low-risk treatment options that may hold some promise in treating COVID-19 induced acute respiratory distress syndrome, sepsis, and multi-organ dysfunction syndrome. Unfortunately, currently we have very few definitive treatment options available for patients with COVID-19 induced ARDS, sepsis, or multi-organ dysfunction syndrome. Over 50% of the patients hospitalized for coronaviruses are likely to develop severe respiratory and multi-organ failure. For these patients, the best we can offer right now involves extensive supportive measures, which include but are not limited to intubation, sedation, mechanical ventilation, hemodynamic support, VV ECMO for some if resources prevail, corticosteroids, and some investigational drugs with unsure efficacy and uncertain virucidal potential. As we know, the morbidity and mortality of COVID-19 is very high, and yet none of these treatment options are promising in eradicating the viral load or curing the patient. Therefore, we must begin thinking outside the box to develop some unconventional treatment options. The first option that I want to discuss with you is the possibility of employing lung lavage with 8.4% sodium bicarbonate solution. One thing we know about viruses in general is that they are extremely sensitive and can be deactivated using chemicals and detergents that are readily available. However, many of these chemicals are toxic and hence cannot be used as part of the treatment in humans. However, sodium bicarbonate is an exception. It is a known virucidal in concentrations above 5% and is frequently used in either on its own or in combination with other aldehydes and peroxides to sterilize foreign produce. The other interesting thing about sodium bicarbonate is that it is well tolerated and has been used by pulmonologists to reduce microbial alveolar count. On the slide, I have cited two papers for your reference, but I'm sure there are more that establish the safety and efficacy of this treatment intervention. If the respiratory status of the patient is such that they can tolerate up to 100 cc's of 8.4% sodium bicarbonate, then I recommend pulmonary lavage with sodium bicarbonate several times a day. On each occasion, one would suggest leaving the bicarbonate solution for up to 5 minutes before suctioning it all out. Another treatment option that might be feasible involves photodeactivation of the virus utilizing methylene blue and blue light. We know that coronavirus is lipid enveloped, single-stranded RNA virus that is susceptible to a variety of environmental conditions and chemicals such as acidity, alkalinity, temperature, and humidity. It is established that methylene blue along with blue light is capable of deactivating COVID in vitro, as can be referenced from the paper published as recently as March 17, 2020. So hence, here is the proposal. We can administer a safe yet substantial dosage of methylene blue in the range of 2 to 3 milligrams per kilogram body weight intravenously and subsequently expose the patient's lungs by placing light-emanating diodes through tracheobronchial and intrapleural routes. The goal here is to target pulmonary viral load. Frankly, I don't see any harm in illuminating the entire patient to an ambient blue light. It appears that it only takes minutes to photodeactivate COVID-19 using this technique in vitro settings. Whether it is going to work in vivo or not still remains to be seen. Now the question remains, is methylene blue safe to administer to this patient population? And the answer is absolute yes. I have been administering methylene blue to treat vasoplegia, which is common among us post-cardiopulmonary bypass patients and septic shock patients. Incorporating light into this treatment is unique but worth trying. I am hoping that biomedical engineers around the world are encouraged to create a medical-grade light source with requisite luminosity requirements in an expedited timeline. Lastly, I want to explore an uncharted territory which involves exploiting the virucidal properties of volatile inhalation anesthetics. Studies from several years ago had established that some halogenated volatile anesthetics inhibit viral replication. However, the question remains, are any of these effective against COVID-19? In the current crisis, we need this question answered by researchers as quickly as possible. If the answer is yes for any volatile anesthetics, we can then administer the volatile anesthetics as a possible therapy to reduce the pulmonary and systemic viral load. The safety of volatile anesthetics is already established, and the hemodynamic consequences of administering high doses of anesthetics can easily be reversed using infusion of vasopressors such as norepinephrine. I just wanted to present a short introduction into some of the potential treatments that may be feasible in curing this current patient population. If you have any questions or would like to discuss with me further, please feel free to reach out to me via email, Twitter, or LinkedIn. Thank you all for your attention.